I'll just talk about the introduction, what the exam is all about. This is, you guys may, some of you may have done the British Diploma exam or maybe preparing for the British Diploma exam. It helps both. So though this course is for the European Hand Diploma exam, but you can have it for your British Diploma preparation or American Diploma preparation or any of the exams. And there will be some trainees. You will have one or two faculties who may have taken the exam more recently, and they joined as a trainee, as an orthopedic trainee or a plastic trainee initially, and then they came when they were doing their fellowship. This exam does come at a wrong time. This time with COVID hovering around, it has come at a very bad time. But thanks for taking time out to attend this course online. So let me see if I can move my screen. Yeah, I can. So that will be the format today. The main emphasis is on the vivas and the breakout session. So we have 8 faculty today. So you will have a full spectrum, which I'll show you the syllabus of the hand diploma. So we'll try to have a full spectrum. And I'm more than happy for you guys to contact me informally afterwards if you need any help or anything needs clarifying. So what exactly is this? It is a mark of excellence, though I said it comes at a wrong time in your life and career, but it adds on to your when you're going for your consultant job interview. And some of you may be already being a consultant as well. But I will only say to you is, I think one thing I've learned from COVID is not to get too hassled. It's just an exam. So yes, you have to have all the seriousness in preparing for it, but don't make it too serious part of your life. That's what I've learned from myself as well. Also, doing 2 diploma exams doesn't help. As you will see, some of the faculties have done both diploma exams. It was just because we paired up and my friends were doing it. That's why I did. There's no advantage of one diploma exam over the other diploma exam. British diploma exam does take a lot of preparation in paperwork. European diploma exam is about MCQs and the clinicals. And those who are orthopedic trainees or plastic trainees, one thing we need to learn from the hand diploma exam, there's always the other side you want to prepare. So when I started preparing, I looked at the other side all the time. So this exam started in 1996, so it's almost 25 years of its celebration this year. And then in 2010, the European Hand Diploma Board was set up, and the FESH was asked to run this sort of format. It did had a phase where there were lots of candidates initially, and then around 2000s, the candidates numbers did decrease. The popularity was lost. And there was a concern regarding standardization of the exam. So let me reassure you, having known the examiners, it is a very standardized exam, both British and European diploma exams, very standardized. All the MCQs are checked. As you will see in some of the MCQs examples I'll show you, just to make you prepare that some of the MCQs are slightly ambivalent. So, and the reason they're ambivalent is that nothing in life is completely black and white. So some of the MCQs can be ambivalent, and how to answer those ambivalent questions, I'll show you with some examples. So we know the structure. You can look into the website and look through the structures. We'll go to the emphasis. It's a big team. So a lot of effort goes in the preparation of the questions, preparation of the cases. In fact, the cases also are screened and are cross-checked that is it appropriate for your exam. So there's nobody there to check you out. Just be reassured about that. And there are examiner of examiners as well who are hovering around just to check that the appropriate standards are being followed. As some of you may have already done it, in my time, it used to be end of November. Keep an eye on the deadlines. With COVID situation, the exams becoming online. It was online last year, both the MCQs and the viva exam, and this will be again online this year. That's what I've been told. So that changes slightly, but be prepared for your things. Those who are preparing for the diploma, who have not yet registered, I'll say go on the FESH website and have a look at the diploma section. And that's how we used to sit for the MCQs at one time. And the MCQs are, there are 300 MCQs. In European Diploma, be careful how you prepare it. So when we were preparing, there were three of us, me, Zaf and CY. And it's good to have a buddy and if a group, you learn far more. So they can be positive and negative marks on the exam format. The French diploma has got negative marking. So my strategy was, you can have your own strategy. My strategy was not to answer, not to attempt a question which I did not know. So I attempted all the questions which I know for certain, and then I went back because it allows on the computer, because it's computer driven. You can look into you can flag those and come back and say, I'm quite sure about it, and then you can answer those. So if you, for example, in my first go, I instead of 300 stems, I did 200 or 140. Then I said, fine, I'll go back and do some more, which I'm quite certain about. So if you're quite certain about, you can just get a bit more marks there. I will not attempt any. And one of my colleagues and very good close friend, he attempted every question. So it's based on what you want to do. What you don't want to do is and answer a question which you're not sure about by taking a guess, because then it can take you, it can rub off all the good marks you have gained with your knowledge. If you look at, I'll minimize you guys here just for so I can see my screen. Have a look at the format. That's why I'll request is to look at the website. There's a lot of information on the website. It compares how it compares with the American board exam as well. Why am I showing American board exams? Because these MCQs are easily available. So I had 10 years of American MCQs. Ask your friend, beg, borrow, steal. And I give it to all my fellows and registrars. But you can have it from your friend and colleague who has the American MCQs. Some of the questions are not relevant for American board exam, but it's 70% relevant. So if you read them, it will help you in preparing. You need to have a baseline preparation, but then it will help you in improving how to answer MCQs. It's an art as well. All of you are senior trainees. All of you are senior trainees. So you've already achieved a level of by the time you plan to sit for the European Diploma exam. But when you prepare for these MCQs, when you do these MCQs, then you get better at the speed of doing it. Judge yourself with timings as well. I'll give you a snapshot by 15 MCQs at the end of this session, just to give you a taster of it. The whole purpose of this course is not to teach you, it's just to prepare you. You're already in the 4th gear, to put you in the 5th gear now, and just to make sure that you are prepared. I went on this course in 2013, and 4 on the faculty were with me in this course. And it's very relevant for this course. It just prepares you. Oh, I'm not that prepared. And that's why I'll say with faculty, those who have stepped forward to be grilled for the viva, it's good to have that. There's nobody judging. And especially if you're sitting in your own house, there's nobody judging. Do not worry. Your average knowledge is as good as your peer next to you. So you may be very good in scaphoid, you may not be very good in something else. And that's where this exam evens things out for you guys. So just look at how much you need to emphasize on bones and joints and the neuromuscular nerves and tendons portion. That is heavily weighted. So don't spend time in too much in the basic science. So if you are taking the MCQ in March, you need to be in the 5th gear now. So start reading the MCQ straight away. And whichever topic MCQs highlight is weak for you, then you can go and read those. Don't start reading greens now, because it's not going to be useful. I did read greens, but I'll come to that. The overall format of the viva, that's the emphasis. MCQs, a lot of people pass. People do fail MCQs as well. So just be prepared that fail is not the word fail, especially in this COVID time. But preparation is the key. So the key is to prepare as hard as possible, especially now. If you're taking the MCQs in March, just overdo your preparation. There's nothing called less preparation. So the viva is 2 sessions. One is on trauma and the other is mixed. of all the degenerative conditions, congenital conditions, inflammatory conditions, and peripheral nerves. Very slight touch on brachial plexus. They don't ask the extremes. Two on a scale of 5, 2 is marginal fail and 1 is absolute failure. Like for any exam, if you give MRCS exam, FRCS Plast or FRCS Auth exam, this exam is also the same level. What they are checking is this person safe? Is this person reliable in their answering? So they are looking at those parameters. And though in British Diploma, there are practical stations as well, in European Diploma, we compensate by checking when you describe a procedure. We, as examiners, get a gauge of whether this person has actually done this operation or not. And that's what you are. And you will be having trainees soon, or you may already be consultants. You will know when a trainee is talking about something, what's happening with that. So as I said, people do fail. Do not take it to the heart. Just give it next year. That's what it is. Just look at, reflect on yourself, what things missed. And sometimes, as I said to you, it always comes at the wrong time in your career. Prepare for the things which you missed last year. And or if you're taking the exam for the first time, make sure learn the pitfalls of taking this exam unprepared. You need a minimum of 3 months. I say at least 6 months. If you're taking both the MCQ and the practical, you need a minimum of 6 months of preparation. If you are not doing anything else, you can do it in 3 months if you are very well prepared overall. But I'll suggest 1 year is always a good start. And some people don't have that luxury as well with the busy jobs. So tips and tricks, go on the website, look at the diploma things, and look at the breakout. Print out the marking sheet. If you are doing FRCS Auth, FRCS Plast, or similar exam, exit exam in your specialty, print out the marking sheet. They all look at the knowledge, the practical skills, the intellectual skills, and the personal quality. When you're answering in a viva session, it should look empathic as well. You should not talk about things as if they are just a case. So that part is important. But other things are matter as well. So the overall ranking mark is decided by, does this person, when we give this certify this person, will this person be safe and carry on these procedures in prospective patients safely? So yes, theoretical knowledge is again, look at the breakout. Please read basic science. Both in British Diploma, there was a session. First module is on basic science. Read up the anatomy of hand and upper limb. If you are doing a long preparation, if you're just starting your fellowship or starting your hand diploma preparation, I use every case to hone down the anatomy of hand and upper limb. It's not the anatomy, we're talking about the surgical anatomy here. And that's what is more important. If you're doing congenital hand, read up the embryology. That's where the viva starts. All slides you'll see today, they start on that session. I'm just trying to keep my time so that we don't overrun the time. And then comes individual sessions on muscle, nerves, and bones and tendons as well. So if this is one slide you take off. It's again on the website, and there's just the syllabus. So this is what I did before my exam. I just sat down with the in the last 2 days. I just sat down with the syllabus in front of me, and it just provides you the whole spectrum of it. So you can look at the whole spectrum, from injured hand to trauma to Dupuytren's disease to nerve compression, anything. And can I talk about these? How much do I know? So if you are starting today, you can always have a rough idea of what you're studying. We all know what our shortcomings are. When I started my British, because I took the British, a lot of us did the British diploma first, and then we took the European diploma. When I started, I knew as a plastic trainee, orthopedic surgery is lacking. The exam is quite orthopedic. I'll just say, as a plastic person, I'll say I'm a plastic and hand consultant. So that's one area. In my fellowship, I just concentrated on the orthopedic side, because that's one area which you think in the hand diploma will cover you. You'll always be decent enough in your plastic, if you have done a good long training in plastic surgery. Same applies for orthopedic. Those who are doing orthopedic surgery, just emphasize more. If you're doing a short-term preparation for the diploma exam, emphasize on the other specialty a bit more. and then look at these topics towards the end. So we are looking at both theoretical skills and practical skills, and common sense. I always say common sense is not very common. So just be aware that if you're asking, if you hear hooves, you always say horse, not zebra, because that's it's again, it sounds patronizing here, but we hear when you sit on a hot seat, as you will see, not only you guys will be sitting in a hot seat, we sit in a hot seat too, asking difficult questions, or making through that whether technology will work or not. It's asking common things first is important, but at the same time be aware of the differential diagnosis, not to miss out any diagnosis which can be life or limb threatening. In this diploma exam, they're not looking for an expert on rare or exotic conditions. You may be the biggest brachial plexus expert coming from Thailand, or you may be the best microsurgeon. They are not looking for that. That's good enough. That's good for you. But at the same time, can you answer simple stuff, and can you answer it in a safe manner? That's the one thing you want to practice on. So that's there will be cases on congenital hand or a difficult congenital hand or difficult plexus, but that's your last things when they are trying to check whether this person is going for gold medal, whether this candidate is even better than what we are marking him on. So they will be checked at the last minute, but don't stress on, oh my God, I can't manage this. But as long as your general hand surgery principles are good, you will pass this exam. So that's what we say when we appoint a consultant. Is this someone I'm happy to leave to look after my patients when I go on holiday? I don't know when the next holiday will come, but that's what. And that's the aim of when you do an overall mark based on your theoretical knowledge, your practical skills or practical knowledge. Can this person treat this patient safely and empathically? So coming to the important bit, sources. What are the sources to read about? Yes, greens, we all get, I gave the copy of greens to people. How much greens did I read? I only read 30% of it. I read McCarthy and Mathis, about 70% of my plastic surgery textbook. And I always wanted to read greens, but as some of you guys will understand, read is very labor intensive. You enjoy, your day is made when you read 3 pages of greens. It just makes you so happy, but you can't finish it. So if your exam is in March, this is not the right time to start it. So I chose portions of it. So I would highly recommend general principles, especially if you're doing the viva. Do read the general principles. I don't remember which chapter it is. So have a read of portions, or if you're doing an operation, have a read around that. If you're doing a long-term preparation, that's how I went about. You can't read page to page. Some people can, and that's what I did when I was a plastic trainee. But I didn't. I thought I'll do it. The thing which I emphasized more, because I was lacking in my orthopedic knowledge, I started reading any orthopedic good text. So I read Tremble's book, and it was an online book as well, so it was easy to read. And then you can emphasize, I will highly emphasize in your surgical career, this book is the most amazing book in hand surgery, Surgical Anatomy of Hand by Lance. I think he has done the class, when you talk about the Lance variation of the median nerve in carpal tunnel, and if you read his chapter in greens, he describes 8 different variations, though we normally describe 3 variations. But if you read his book, I give it to my trainees and fellows as well. This book is actually a great book, and I highly recommend. You can't read it for this exam, but you keep it for your career, and you keep every time you're doing a complex operation, you can go through it. If you hear big speakers like Susan McKinnon, she brings an anatomy book. There's no shame in bringing it and keeping it there. We are all learning. Not everybody knows every stuff. People keep telling that, oh, this person is so good, this person's knowledge is very good. The more you discuss it, the more you learn it. And that's why having a buddy is good. And that's what I did in my preparation. I had, you may see Zaf later, and CY, 2 of my friends and colleagues whom I work very closely with. they were my buddies, and because they brought the orthopedic experience, that's how this exam brought us together, and we're still together. It's have a team, and you can do it now with Zoom. You can have teams across the world and make friends during the preparation for this exam, and that will carry on with your surgical career, hand surgery career as well. I emphasized on journals. So people who are looking for journals, based on whichever region you come from, you can read your own journal. The exam is English based. They do give leniency for your language as well. So that's one problem they are overcoming over the last 10 years, this decade. They have worked to overcome that as well. I emphasized, I know we read our British Journal and British and European Journal, and some very good articles on it. So I looked through those articles. But I just, when I started preparing from this day, I sat down in my library in Birmingham, and I was doing a fellowship 8 years ago. And I looked through all the last 5 years of Journal of Hand Surgery. And I highly recommend, I make a folder of it now, and I've given it to my trainees and fellows, those folders, so they don't have to do it. But you can do it yourself. If you have access to American Journal, there are 3 sections in that journal. So that one section is called Evidence-Based Medicine. So it's only 3 pages, and there are short cases. And all the short cases, this is not a good example, but just to show you that these are OSCE stations by themselves. So there will be one on scaphoid unit injury, one will be on a glomus tumor, one will be any topic. And it starts with a short history, short examination, the investigations you do, and that's how you prepare for your OSCE stations. So that's what I did. I prepared the last 5 years. So one section is called evidence-based medicine. One section is called current concepts, and any other topic, any important topic which you think you don't know about, when you're skimming through it, you can have those, or just do these evidence-based medicine and current concepts, and you will fly. That's what I did. That's how I prepare. Everybody has their own way of doing it, and you must have already been on that path. These tips and tricks are for you to look into the right direction in short piece of time. I'll highly recommend ours because of the British Society. I joined the instructional course in 2008 to 2010 series. They do twice a year. I'll highly recommend them. If you've done it on 2 days of teaching, I think there's one following today. I think Professor Lam is going to teach on that as well. But I'll highly recommend, if you can get a booklet of that, even better. But if you can attend it, great. I attended as a plastic trainee, and then I went back because my knowledge of wrist was not great as a plastic trainee. So I went back to do that course again. And it's a theoretical course, but it's very relevant. So if you have friends, you can get the PDFs of those. That's great. Or just look at the program. And those topics are so well discussed, like a mallet injury or a scaphoid unit injury or mid-carpal instability. Those topics get so well discussed in these courses and becomes very useful. I'll highly recommend for people taking European diploma exams, people from all over the course, they come around. So that's very helpful, this course. And we don't have, I think, because there's no exam, these are the places where this is a great way of visiting these places when you're taking the exams. I'll show you, we were in Turkey when we took the exam, and we were on a beach a day before. So what I will suggest to you guys is, when you're answering questions, if the topic is on, if they show you, they use the first slide as a prop. So don't worry about if it looks very simple, and the question starts from very simple, from basic signs, like a nerve injury or tendon injury, start from tendon healing, and then they will take you to the latest evidence. If you can quote an evidence, great. It's considered high order thinking, and evidence quoting is important as well, as long as you can defend the evidence in a right way. Don't start, because people used to tell me that I knew too much, which I deny completely. Is try not to start telling the evidence in the first line. Sometimes too much knowledge is difficult as well. So if you have this template, like, well, for example, talking about flex, and you can apply this template to anything, to a hand fracture, to a reimplant, to a tendon injury. So for example, or extensive tendon repair, what is the philosophy for that topic? What are we aiming for? and what are the challenges. That's how you, challenges are mainly the consent, how you consent, and you need to be aware of it. If you not mentioned CRPS in a nerve injury problem, then they think this person doesn't have insight or he's not done enough. So that's where, when you sit down with yourself, have a look at those things as well. I'm going to keep an eye on the time. So same thing applies for reimplant. If you see a patient slide with a reimplant on, do not jump in talking about or the minutiae of doing it. You may have done hundreds of reimplant. Look at the bigger picture. Anything you're answering, or if you jump in, just pause before you end. Have that internal clock in yourself. Then pause and say, can I talk about something else? Can I talk about the amputated part? Can I talk about the whole limb, the patient, and how the team, how the referral is taken, how the part is preserved? Do not assume anything. They may prompt you if you are struggling, but you don't need the prompt. You just keep going. Be aware that more and more of the exit exams and senior exams now, the examiners are meant to have poker face. They will not say to you, excellent, well done. So don't worry that you're not progressing well. But that's what comes, and that's why viva sessions are important. You can run through those. Again, I'm just going to show you some examples that if there are some cases, you look at the picture, and just say what you see. Just if you don't know what it is, for example, if you've not done plastics or you've not done congenital hand, or you have a very minimal exposure of congenital hand, just talk through what you can see. This is, just remember that when you become a consultant, you don't know everything. So what do we do as a consultant? What do we do if we see something very rare? We try to know what we know about that. How do we investigate it? And whom we can ask for help. And that's exactly what you do. That's, you don't jump in and start doing things which you're not comfortable with. That's what you say. What you can't do is, I'll refer this to this, I will refer this to, you can't say to all the cases shown to you. But at the same time, you want to highlight and show that you have that insight to manage a complex patient. So if you have upper limb, describe the correct terminology. Classifications are not important, but some of the classical classifications, if you know it, it gives you a good talking point. So what I did was, I prepared for the first 2 minutes. Can I talk for the first 2 minutes in those? I'm just looking at any text just to check that we are okay with time. And I'm just be aware of that my other faculty will also join in at the end of this session. So in congenital hand, that's what I did. At this moment, I go into salvage mode. How do I prepare? How do I pass my exam? Yes, getting knowledge is the ultimate aim for any human being, but passing the exam is your short-term goal. So if you're doing congenital hand, do these 5-6 short cases, and then if you're very good, you can look for other cases as well. Don't get thrown out. So if you're an orthopedic trainee, this is one of my patients, and that's my first station which I got in the British Hand Diploma exam. So you can get that. So this is a miscellaneous group. Again, the purpose of this today's session is not to teach you the whole spectrum. It's just to give you a taster of what you are, and to highlight, without judging you, highlight what are the areas of your deficiency deficient in, and then you can work on those deficiencies. So so that's the burn hand I got. I can talk about it at the end. We'll come back at 12:30. Or a spastic hand, or a rheumatoid hand. What you're talking about is how do you talk in principles? Don't jump into the hand there. Just look at the whole upper limb. Learn the principles of management of rheumatoid hand, spastic hand, burn hand, that it starts from the hand is attached to the body. So think of the proximal areas. You have to release the elbow and the shoulder and the elbows before you start controlling the hand. They may say, that's fine, ignore the other things are okay. Similarly for rheumatoid hand, don't forget to mention about neck. These are common sense things. Say, I will not do it. But sometimes when you're sitting on a hot seat, your level of performance in the exam is about 66% of your actual level. And we also understand that we all have been in that position as well. So just be aware of it. Just to give you a spectrum, you may see a case like this, and then you may get a panplexus. If you're doing very well, they will show you this and say, what will you do? Don't get puzzled. If you don't know, if you're not managed brachial plexus, is this not to highlight? It's just to go back and talk in principles. Any topic which is beyond your comfort zone, talk in principles. We will discuss this in breakout sessions. Just to show you, this was passing the British Diploma exam. You will see some of the faculty today. And this is the time when I had a mustache. I'm not sure whether you guys can see me, and this is the triangle we had. We had this. The Three Musketeers, and you will see we were far more happier in the FESH exam. The British Diploma exam was in March and the FESH was in May. So we were relaxed. We had already passed one exam. So these two cool guys were very relaxed, and we were on the beach a day before the exam. So that's how the exam was. So yes, it does kick in when you sit on the hot seat. It does kick in your stomach for 5 minutes, and it's a general chit chat. Just let me reassure you, it's general chit chat, and you all will do well. Now I'm going to just take a 2-minute break. If you have guys have got a pen and paper, I'll have my tea while I'm giving you MCQs. Because we don't have that much time, we'll do 15 minutes of this. Or 14 minutes of this. I will give you the answers at the end. I will only give you 30 seconds. So if you want to, I'll pause for 30 seconds for each session. You have to answer every as true and false. So actually it's 5 marks if you get all of them right. So I'm going to pause for 30 seconds and move to the next one. You can put your comments in chat, and then I can read it at the end of the session. Probably I will not be able to read. I'll move to the next one. While you're doing it, you can see what I mean by ambiguous stems. Sometimes some stations can be ambiguous stems. It's slightly different because when you not see face to face, you don't realize that the other guys, that you guys are, there's no visual feedback from you guys. So when I'm going through the answers, I'll go through them again. So don't worry if you miss it. I'm going to go through the answers again. As I said to you, this is not to teach you guys or to give you the answers of the MCQs. You can have this MCQ anytime. I need to go back. I think my slides have moved. So I will go back to that slide again.
Yeah, we missed that bit.
Yeah. But you on this?
So, yeah.
Yeah.
Please. Foreign muscles. Foreign's plus. Oh, this is plastic.
Just remember that I'm going to come back on this. I'm going to come back on these when I'm discussing the answers with you guys. So even if I'm going slightly fast, it's just because my other colleague is waiting at 20 to start. So this is just a taster for you guys. So when I discuss the answers, that will be another time to go through those questions again. So I can't look at the chat, so you can come and look at the comment. So and then when my friend Zaf will talk about his tips and tricks, then I will have a chance to answer some of the chats at that time, or I'll do it at 12:30 at the end. So we'll go to the answers now. So just you guys can just look at the answers because my colleague Zaf is almost ready. So I'll run through these. Um, this is just to highlight, some of the stems are try to confuse you. So what I used to do was I used to just put my hand and just look at what the answer is, and then individually write true and false in your topic. Some of them look, you may mark them as false or true, and then you get a negative mark. This is a straightforward one, so no problem at all. And some of the questions you will see, I will highlight them like this. You have to really, it takes time, and that's why you need 1 minute per stem for one question, because you have got 5 answers there, and you need to know about the surgical variations. So if you're not sure, just miss it. So and you can, if you know about the variations, you know that it normally has 2 tendons, 1 tendon in each subsection, and sometimes you can have as many as 7 tendons. I don't know who has seen 7 tendons. I've seen 3 or 4 and sometimes 5, but never seen 7. And never use never and always in medicine. This is what we say. So if there's something which says always and never, highly likely that is going to be wrong. But don't make generalizations. Again, don't make generalizations on topics as well. And that's why the MCQs are important. It refines your knowledge and it picks out who is better than, who's far more prepared and who's less prepared. You can argue this bit, if you look at this, acute mallet fracture, unless until you're a young person with hypermobility, swan neck deformity with mallet fracture usually takes time. So what we call as chronic mallet, described by Dio, when you have mallet injury for more than 6 months or ignored mallet injury, that can lead on to the next joint becoming developing swan neck, and that's where the problem starts. So they may not have a problem to begin with, but they may have a problem afterwards. So you may not develop it. Some people may argue they may not develop it. So that's where the discussion starts sometimes. In viva, you can defend yourself. In MCQs, you can't. If you're not sure, I will leave that bit based on it can go wrong. So it's slightly ambiguous question. They also, and that's why the examiners sit, as I will mention it, sit at the end to highlight it as well. So if you know the opponentsplasty, we know what are the different muscles used. EIP is the Burkhardt one, Bunnell's one is the FDS. We don't use ECRP. We don't use PT, and we use the Uber one. The one which is called opponentsplasty, or it's called abductoplasty, is a Kamitz transfer with palmaris longus. If you read about Dupuytren's, there were lots of papers, carpal tunnel and Dupuytren's. Finally, they have come out when they looked at the diathesis. They found out the carpal tunnel decompression was not. It's basically sometimes the trauma is an inciting factor for the Dupuytren's disease, but actually there's no correlation between that. But PIP and the MCP joint, yes, it is. So you can see that some of the questions, you may have read one paper and then you can answer it wrong, but just see overall what's the consensus on that topic. CMC joint arthritis. Again, what do we do for CMC joint? Anka has got some slides on that. We'll discuss this. So common topic, be prepared. There are some topics we can't do without. So this is one of the topics of those. If you have pan-trapezial arthritis, what do you do? How do you do trapeziectomy? When do you do hemitrapezoidectomy? You just be careful of the words and what's the role of interposition arthroplasties? What's the recent evidence for those as well? And that's where things are. Some of the questions can be ambiguous. This is again a viva session as well. It's always asked about when you're consenting patients. You look at age is not an important factor. Digit involved is not an important factor. But passive DIP motion is important. Like for any tendon transfers or tendon grafting, you may want to make sure the joint is supple. Retraction is the most important factor here, because if it retracts into the palm, then the whole pulleys collapse. And if it has the chip of bone, then yes, the pulleys will not collapse. You can do it as late as 1 month or even longer. But that's rare. Just be aware of the evidence. And that's why you need to dissect each stand separately as well. We all know the flexor tendon. This will be asked. We We know the number of strands are important. We know the type of suture is important, and mobilization. So sometimes when it's all true, most times those are the right ones. You can again argue, people will say the zone of injury has an influence as well. So, but the strength is not. Just be aware, when you look at that, zone of the injury is important. Zone 2, zone 2C, it's considered the black box. Some people don't even repair. If you hear Jibotang, he will be talking about, or Mr. Elliott, he'll talk about zone 2C. But it's not, that's not the question about strength. The question is about strength. So just before you answer, choose that answer, be careful as well. I've just shown you some examples of the MCQs because that's where 70% of the MCQs are straightforward, 20% are difficult, and 10% are ambiguous. The answers can go either way. So you can leave them if you're not comfortable, not to get a negative mark. I've discussed this opponents plasty already with you guys. And then it's important to know the true anatomy, and that's where surgical anatomy becomes important. Sometimes you can miss out, like pronator quadratus, pronator teres. So you need to know individual muscles, and that's basic knowledge, anatomy knowledge. So that will be tested. And that's the great time to check the MCQs. And that's why the MCQs are slightly more tougher, because they are checking for your basic science knowledge. And the common topics, human bites, animal bites, we do this all the time. So you want to be very good with those topics. So it's looking at the commonest organism. They're not talking about the most common. So if they say most common, then you need to know what the most common. So is a common, so it's slightly different one. So you need to know what means usual. What does usual means? Just be aware of it. And then they may give you a rare operation. So it may not be rare for you, but it's quite rare. And then do you know about that? So if you've not seen this, done it, or read about it, just skip that whole stem. If you don't want to get on with it. But I will not skip it completely. I'll still read it and then say, do I know about it? Did I hear it from my colleague? And can I answer it? The chance that you will get it wrong is slightly higher. So I'm going to stop here with tumors of the hand, and then just invite my friend and colleague. We have been doing this for ages, just to show you quickly answers, the last two. And this is not to teach you. This is just to give you a taster of what the answers are. And I will let... this will be discussed with me and CY again in greater detail when we're doing the viva sessions. So I'm going to stop here and invite my friend, if Zaf is around. I will come back to it if Zaf is not able to make it. I'll just check it. Let me see. Zaf, are you around?
Hi, Anuj.
Yeah.
Can you hear me?
Yeah, let me just stop share. Shall I stop share now? Yeah.
Thank you.
Yeah. Thanks, Zaf, for the patience. I love your fresh hat.
Yeah, just for you today, just for everybody. So thanks for having me on again, and welcome to everybody. My name is Zaf Nakwi. I'm a surgeon in Manchester, and I'm a candidate, a successful candidate, like many of the faculty here on the course, and close friend of Anuj and CY, and we did the diploma together, both the European and the British. So I'm going to share with you a presentation. Hopefully I'll be allowed to share. Looks like I can. Here we go. Can everybody see that? Someone give me a thumbs up. Can people see that? Okay, thank you, Jack. I can see you there. So it says a candidate's perspective. To be honest, as a disclaimer, in reality, that was back in 2013. I can give you from an examiner's perspective now. I examine for both the diplomas, and that's probably more useful for you to have the examiner's perspective as well as a candidate's perspective. But there are lots of successful candidates here as your faculty. The first thing to say is the smartest thing you've done is to be on this course, because that gives you an immediate advantage in terms of how to mitigate or get through this exam. So really, from a candidate's perspective, this is the situation that you're all in right now. This is not the time to be doing another exam in your life, but this is the reality that you're facing after having done FRCS and various other exams. But the issue here is, and it may have been mentioned already so far in the course, is that we are coming to hand surgery from two different areas. And so because of that, fundamentally, something like this diploma, it is critical and key for you to have a comprehensive understanding of hand surgery. There's very few places in the world which deliver hand surgery as its own specialty. And so you're coming as a general surgeon, an orthopedic surgeon, a plastic surgeon, this means you have to become complete. You have to learn what the other half have learnt, and vice versa. So what are the examiners looking for? And it's quite simple, really. They're looking for a consultant colleague, and you will be treated as such in the exam. You will not be treated as a trainee. You'll be treated as if you're someone who's in a clinic and doing an MDT with them, and you will be treated at the same level as the examiner. And that's really important for you to understand in terms of the level of your maturity and approach. So for example, simple things, answering a question like, you could do this, you could do that. That is not the way to answer these questions. The way to answer is to say, I would do this, I would do that. And because that's what a credible colleague would be talking about. The other thing about this exam is that I think that it's on a spectrum of dove and hawk. There are more doves who are examiners than hawks. And because of the way the origins of this exam is, it's been set up by people who loved hand surgery and who want to show its appreciation of the people who've taught them. And on that note, I don't know what has been mentioned because I've just joined, but I would like to state how sad I am today to learn about my tutor and my mentor and my teacher, Professor John Stanley, who passed away yesterday. He was a great man and he taught me a lot, and many people a lot. And he is one of those pioneers of hand surgery that I'm talking about, people who have really put hand surgery as a defined hand surgery in the contemporary sense. So this exam is there for people to create something that wasn't there for the original people who'd come from orthopedics and plastics and different specialties. My own experience as a candidate and as an examiner, that this is a discussion between peers and friends and enthusiasts and lovers of the hand. I sincerely say that, and that's the feeling you will get at the European exam, at least, is that this is a discussion of people who are enthusiastic and get excited about hands. And some of the examiners, for sure, are looking to learn from you. I don't say that in any funny way. Candidates their enthusiasm comes through, and they can teach us things as examiners, and it's lovely to get the experiences. I think it's a fair process. I think it's a friendly process. It has become more standardized, and I'll talk to you about that. They're after what you know, and so if you're getting continuously picked at, don't think it's because you're doing badly. It may be because we're trying to raise your mark. Certainly when I'm examining, that's exactly what it's about, is that if I keep going at you, it's because you've already scored the points and I'm trying to raise you higher and higher, because your points in one question can then help you where if you do badly in another viva. And so it's really important, if people keep persisting and pushing you, it's probably because actually they can get you more and more marks. It was practical and experience based. You're probably aware, Fesha's probably written to you, that we decided last week or the week before, we decided that we are going to do it all online this year. So obviously that means no practical. But when I say practical experience based, this is case based discussion. These are genuine cases. There was a practical element the year before where you were repairing a flexor tendon, but obviously that's not going to happen this year. The format Anuj has discussed. We're focused on the European today. The vivas, in fact, this is changed now. You will know that there is more than 2 vivas. There's 3 vivas, and I think they're half an hour each. You will find it fairer and better for yourself, actually, because you're going to get different examiners at each time, and the 30 minutes is easier for you to survive, and things are far more structured. and it will be via Zoom. So it will be like this. I'll be, you'll have a slide and you'll be asked to talk about it, as Anuj has already discussed, and as you'll do later on in this course. In terms of my preparation, I think the CY will tell you the Chinese proverb of no understanding your enemy. So what is your enemy? Your enemy is your weaknesses. So if you've come from orthopedics, you're going to want to really focus on the skin coverage, soft tissue coverage, brachial plexus, congenital hand. And as a plastic surgeon, you need to focus on scaphoid, wrist, carpal instability, fracture, basic science, etc. What did I do with my colleagues, with Anuj and with CY? We did the instructional courses, which are on, and I think there's one coming up now. Definitely did the instructional courses. I did a cadaveric course as well, which is fundamental for anatomy. I think anatomy will help you. Having a deep knowledge of anatomy, going back to it now, will really help you for the MCQs. Because if you think about it, you've got a number of European countries, all of whom manage hands differently. So the content for your MCQ has to be as least controversial as possible. And so the least controversial topics are anatomy. I mean, there's controversy in anatomy as well, but if you go back and revise your anatomy now, first of all, you'll enjoy it. You'll enjoy your anatomy because you were learning it first time round because you had to learn it. When you go back as a hand surgeon and rediscover the anatomy of the hand and the upper limb, you will find it so enjoyable because it will relate to your practical day-to-day life in terms of delivering your own surgery, and it will become relevant. You'll pick out things you didn't see before when you go back. So that's true revision. Revision courses, you're on one now, so that's put you in an advantage. But I think for me the key was group study. So as Anuj mentioned, orthoplastic group, if you can get that, then you're on a very, very good position. So if you can find a plastic buddy, if you're an orthopedic surgeon, then you will share each other's knowledge and you will reassure each other, because you all know that when you're reading a textbook, you don't know of a new subject, you don't know what's the important bits here. It all looks important. You can't memorize greens. But then when you speak to someone who's practically done orthopedics or plastics, they will help you pick out what's relevant, what's important, and what's actually fine detail. The materials, books and videos I'll talk about, and MCQs, there are also bullets online. They are the ASH MCQs, but in fact, they're very different to the European MCQs, which Anuj has just shared with you. What did I use to read? I used Greens as a reference, or when I was having insomnia and I needed to sleep, because I started reading Greens and it would help me go to sleep. But to actually memorize, I was using the CKO of hand, shoulder, and elbow, which I thought was fantastic. Each topic on 2 pages. It was brilliant. I used the Oxford Handbook of Hand Surgery because that is ideal for when you're in a clinic, when you're in a list, particularly these days, and there's so much waiting around. Things are so inefficient right now. Having something in your pocket that you can just read a page is a fantastic way to absorb all those wasted minutes during your clinical practice. And Hand Secrets as well. Those are the 3 books I used in reality. And then we shared papers between us as a group in our study groups. What was I asked? Here's what I was asked in the British and the European. I don't think there was anything that was unfair. If you look at it, you would think these are all fair topics. Thumb reconstruction, I was able to go through all the different options of thumb reconstruction, all the different surgeries, and the complications, and quote some literature. And that's what you want to do to get top marks on each of these questions, is if you can do that. And you know, for me as an orthopedic surgeon, being able to talk about congenital hand, thumb reconstruction, replantation, it was a very good time to learn that, and to, you know, the great feeling as a hand surgeon to have a complete picture of the hand. So the rest are really holiday snaps, because we're very short for time. I was going to stick to 10 minutes, so I think we're there. But you've already seen this picture. There's Mr. Mishra with his tash. This is where I did my exam for the FESH, but unfortunately you will be doing it sat at home. And here we are, and this was the result there as well. But this is the ultimate, really. It's a complete perspective. And once you've been through this process, you will really appreciate the hand far better, and you will have a better practice, and it will impact on your patient care. So it's the right thing to do. Those are my emails. If you need to get hold of me or through social media, it's just @Zafnakwi. So I'll stop there, and I hope that was okay. And I don't know whether we're taking questions, but I will unshare now. So someone's asked what CKO. It's Core Knowledge of Orthopedics. CKO. It's a textbook by Trimble. If you look it up, it's I found that really useful as a 2 pages on each topic, 2 pages of A4. Great way to revise. Comprehensive.
Sorry, what did the DD stand for on the British list? The topics asked. DD, the very first one. Yeah, on the British side, the first thing was DD. You know, I didn't get what DD is.
DB.
DD, double D, delta.
Oh, Dupuytren's disease.
Oh, Dupuytren's disease.
Yeah.
Okay.
Yeah. So some of those questions, like a Dupuytren's question, you really need to, you know, this is entry level stuff. What we're looking for is and it's to make you feel comfortable. And hopefully, as a hand surgeon, you should feel comfortable if you get a Dupuytren's as your first question. And that's the way the vivas are structured. There will be kind of a settling question. Then we will ramp up the detail in the questions. And I think it's really fair. You'll have 2 examiners. You'll even have an examiner examining the examiners. We'll mark you out of 5, that everything is averaged. And so Vishal is asking me, are the exams equivalent? Is there an advantage of doing both? So the exams are, it depends who you're asking. So if you're sat in Europe, then obviously the European exam. But if you're talking about jobs, then both diplomas will be equivalent. They're not equivalent in terms of, you know, the British diploma is a course, and the exam bit of the British diploma is one component of that course. It's very different, whereas the European exam is a viva. So I'm going to leave it there because I have to go now. But thanks, and if you've got any further questions, you can come back to me by email or by social media. Thank you very much.
Okay.